Good evening, everyone. Want to thank you for joining us um, for this end of the first day of our summit. And I'm so excited about this town hall conversation that we are about to have. I want to set the stage a little bit with one little slide that I'm going to ask them to put up right now that hopefully will center our conversation um, for this evening's town hall. So Nina, if you'll put up that slide for me. So one of the things that really struck me as I was looking at data, and everybody who knows me knows that I'm a complete data hog. And the thing that strikes me the most about this particular set of data is that government-sponsored healthcare is just about to overtake the employer-based healthcare system. So if you take Medicaid, Medicare, and the VA, that's about 45% of everyone in the country in healthcare is getting their healthcare through the federal government. The employer-based system is at 47%. And what is going to happen as our population ages, the government insurer base is going to increase. And what that essentially means, at least in my eyes, is that members of Congress and the Senate will have a lot to say about American healthcare. It's certainly one of the lessons that I've learned over the last 20 years is that healthcare policy is a branch of medicine, that it defines pretty much who has access to what, how long they have access to it, who can give it to them. So I'm really excited about our participants of this afternoon, this evening, because it is their voice that is going to shape American healthcare in the years to come. So it's with a great pleasure that I introduce Dr. Ami Bera, who is chair of the Congressional Asian and Pacific Islander Caucus, Health Braintrust, I'm sorry. He is a physician. He's also married to a physician, and he represents the people of California's 7th District, which is around Sacramento and the surrounding areas. And then we have Congressman Darren Soto. He is an attorney. He represents Florida's 9th District, which is Orlando and its surrounding areas. And everyone knows our great friend, Congresswoman Robin Kelly, who is we've been working with for almost 20 years. I think we're getting younger actually by time. She's married to a physician, and she represents the people of Illinois' 2nd District, which is South Chicago and Chicagoland area. And so I want to thank them so very much. So I want to begin the conversation because about COVID, and we all know what a devastating impact COVID has had on our community. When you start to say 575,000 Americans died in a year, you really start to talk about a very serious set of numbers, particularly in minority communities. And a lot of that happened in the Medicare and Medicaid programs. And so I'm going to ask each member, starting with Dr. Bera, to talk about COVID in his community, his district, with his constituents. How did it impact them? What did we learn from it, if anything? And how do we go forward from here? So let me start with Dr. Bera.
Yeah, thank you. And thank you for the invitation. I think what COVID did was it exposed what many of us in healthcare already knew occurred in terms of the inequities to access to healthcare and under-resourced in communities of color. The more chronic illness that goes along with the lack of access to healthcare and the lack of resources in many of these communities. And when the pandemic hit all across the country, the communities that were hit the hardest were the ones that had the fewest resources, the fewest access to healthcare support, were further away from hospitals or had limited hospital and clinic capacity. And that manifests in the data that Black and brown communities were hit the hardest, suffered the most illness, suffered the most death proportionally. And you see that as we're rolling out the vaccine. These are also communities that have had less vaccine uptake than more resource communities. So we find ourselves, and we as members of Congress, but as a country, find ourselves as we tackle this. It's right out there in the open. So let's actually once and for all try to address that healthcare equity question. So we can start to address the underlying impact in these less resourced communities. Here in Sacramento County, it's the same thing as you're seeing all across the country, that Black and brown communities have been hit the hardest. I applaud the Biden-Harris administration for recognizing that in terms of vaccine delivery and vaccine, and particularly putting resources to go into these communities, but to partner with nonprofits, churches, and others that are trusted elements in these communities to try to get the vaccine delivered. But one of our colleagues, Barbara Lee, who has been a champion for these issues, also made sure as we go out and hire those healthcare workers, as President Biden says, the vaccinators, that we don't bring in outside individuals that are coming in, but we actually go into these communities and try to identify folks from these communities, train them up, and create a public health workforce to address these inequities. But there's an opportunity for us to undo a lot of what we knew existed for a long time.
Thank you so much. Congressman Soto?
Thank you for the opportunity. And what a theme. How does racism make us sick? We know COVID-19 has really laid to bear a lot of these reasons why institutional racism and just general institutions of the United States have done that. In the Hispanic community, first, we see more overt racism in the form of anti-immigrant moves to deny vaccines to farm workers and other immigrants in the community. On the federal level, thank God, we don't check those types of IDs. We don't. We encourage for all folks, regardless of immigration status, to get vaccinated, and we cannot use that information for enforcement purposes. But in Florida, we've seen them ask for ID, and it's discouraged some folks. Another more overt way it hurts the Hispanic community is whether or not there's bilingual communications being put out there for health notifications, everything from vaccines to new insurance opportunities and the like, all key in multiple languages, including in Florida, both Spanish, Creole is another major population in the Sunshine State. That without those bilingual communications, you're not reaching all communities in Florida. Then you have more latent institutional barriers. First, coverage, and we saw a huge increase in healthcare coverage after President Obama helped pass the Affordable Care Act. That actually is the way nearly 2 million Floridians get their healthcare, through the federal exchange, the largest federal exchange in the nation. In part because, as was discussed early on, discussing employer-based healthcare, a lot of Floridians don't have access to employer-based healthcare. They're working in the service industry and tourism, and they may not have that more traditional employer role. So they're getting those that health coverage, and that's improving through the Affordable Care Act exchanges. And President Biden, of course, has kept open enrollment now open for several months. We're seeing increased enrollment. Why? Because we're in a pandemic and we want people to be covered. We know that not only for COVID purposes and the response, but also pre-existing conditions make people more vulnerable. And coverage and primary care on the front end avoids pre-existing conditions on the back end, making communities of color more vulnerable. Also, resources aren't always perfectly distributed throughout our state. For example, our state has still refused to expand Medicaid, even though we made it that they would draw down more money now after the American Rescue Plan if they expanded Medicaid. This leaves about 1 million Floridians who are working poor, essentially. Many in my district who are working 40 hours a week or more, putting in their time and still unable to afford insurance, like 2 folks who work at our local theme parks and have 2 children, a family of 4 in my district. They'd fall in that gap along with 1 million people, too poor to qualify for Medicaid, but not making enough money to be able to afford the exchanges under Obamacare. And then, of course, even healthcare providers can sometimes be an issue. I am proud of the fact that that at this point, most Americans are within 5 miles of a vaccination center or pharmacy in the National Pharmacy Program or federally qualified health clinic or hospital. These are all huge issues. But what gives me hope is the picture behind me. That is a picture from the Oval Office this past week where the Congressional Hispanic Caucus met with President Biden and Vice President Kamala Harris. And we talked about a lot of these issues. And they listened and they responded. And they already have been working on a lot of these issues. First and foremost, in addition to making sure we had enough vaccines, passing the American Rescue Plan, and getting out a lot of distribution through the vaccine community centers, the National Pharmacy Program, through federally qualified health clinics and others, they have the Vaccine Equity Task Force led by Dr. Nunez Smith, who is incredible and is working on with us each in our districts individually to expand this ability. In Central Florida, we've seen these national vaccine sites be key. The pharmacy sites have been key. We see a lot of Central Florida be vaccinated, 16 and older as who's eligible, but we're still seeing a lag, particularly more among men and even among men in communities of color. And I think part of that is misinformation, part of that is historic discrimination, of course, fear because of that. And so the outreach is key through the faith leaders and civic leaders like the NAACP and Hispanic Federation, as well as working and doing constant tours. And Congress has to lead with oversight, with policy and funding to bridge these gaps. And we as individuals have to lead. I know in the Hispanic community, we don't always have the best diet. We don't always exercise as much as we should. This has led to generations before me having diabetes or a greater chance of it, or heart attacks or other issues with that. So both Congress has to lead and we need to lead and set by example to lead healthy lifestyles to improve those health outcomes along with coverage and funding and all these other things. So thanks for having me here today. It means a lot.
Well, thank you so much for your comments. Congresswoman Kelly?
Hi, good to see you again, Dr. Puckrein, and good to see my colleagues. You know, the numbers around COVID and the Black community might have been shocking, but not surprising, as my colleague talked about earlier, that we've known forever that there's been health inequities, lack of access. We talk about the social determinants of health, but I say the social determinants of life, you know, lack of access to healthcare, education, you know, poverty, the job you have, and those kind of things. And so COVID just, you know, shone a big spotlight on the issue, and Black communities had later access to COVID-19 treatment and now the vaccine. I do think in Illinois, my governor and the mayor of Chicago have done a good job and actually the Cook County board president have done a good job in trying to get the vaccine out. But at first, you know, if you didn't have a car, like in the suburbs, there's no bus or subway, you couldn't get to it. So that made it very difficult because a lot of them would drive up, but there's a lot more places now, I'm happy to say. So a lot more availability than it was initially. The other thing is many essential workers are African-American, and they had to report no matter what, through the pandemic, and often with insufficient PPE. Also, the other thing, we talk about a recession, we say a she-session, because so many women suffered because of COVID, and Black women are the most affected by the COVID recession, with much higher rates of job loss than their white peers. So not only the physical sickness itself, but also when it comes to, your pocketbook, many of us, suffered anyway. And then also just the issues around mental health. That went up in, not only my area, I know, but it's something we talked about in my area. And also the other thing that went up even is gun violence. It was up 50% from what it was in 2019. And this year it's up 31% in the Chicago area than in 2020. And so people are really suffering because of this disease. I do think, because of our work in the American Rescue Plan and what the president hit the ground running, that I think we're coming out of the dark, but, people do have to be responsible too, get their shot when they can, wear their mask, and, physically distance and wash their hands. The government can't do it alone, but we can play a very big role.
Well, thank you so much. What I should say to you is the audience and participants who are listening to you this evening are activists and from all over the country, and they want to help. They are committed and they want to understand. So what can they do to make your job easier, to help us transform this system? And I'll phrase it this way, because I think it's always important to understand from whence we came. The American healthcare system as late as the 1980s and 1990s still suffered from the old segregation system where inequalities were really acceptable, both by law. I mean, really, we didn't bring down segregation in hospitals until the 1970s, and even in medical societies and places like that, discrimination continued. Now we're trying to reshape the system so that it provides equality and equity for every patient that comes through the door. But that's a lot of work, and we need to be able to help you. So what would you say to patient advocates? What can we do? How do we know we got to vote. Everybody here knows it all starts with, we got to vote, right? No question about it. We got to stand in line no matter how long the line is. If it's 2 days, we got to stand in line for 2 days. So we got that. But how else can we help you bring the message forward and starting with the reality of what we saw with COVID? Representative Soto, what's your thinking? You're on mute. I'm sorry.
Yes, I think there's two key things that I'd ask for today. One is be our eyes and ears on the ground. I'm doing oversight events each week. I'll go to a national pharmacy program location, a hospital. I went to federally qualified health clinics. So I'm trying to see as much as I can, but I don't know where we're not everywhere all the time, where a line may be too long or where a vaccine site in the district may run out more often than somewhere else across town that may be more affluent. There may be a lack of COVID tests in a region. You have an area where there's immobility and we're not getting mobile units out there. All these different things. We're not engaging local pastors enough, or local imams or rabbis, or the civil rights organizations like Unidos USA or NAACP. These are key areas that you need to keep our members of Congress abreast of, because we can help identify that for the Health Equity Task Force, for the administration. We can make calls ourselves. We can show up. We do that real well, show up where there are issues. And a lot of these things we have to manage ourselves. We have to be the eyes and ears on the ground so that we can identify where the issues are, so we could do proper oversight to make sure we're filling in these gaps. Number two, and it was already mentioned already, under the American Rescue Plan, we funded 100,000 vaccine outreach positions for local departments of health. So if you know folks in the community who want to help knock on doors to help spread the word. I know even on my door, we had a notice of get your vaccine. My wife had already did that obviously a while ago, but being in a blue collar kind of mixed Anglo-Hispanic neighborhood, they were just checking, of course. And so we want to make sure that local folks are being hired. So if you know qualified folks who may be out of work, who are interested in that and want to start a good foot in the door to get involved in more healthcare profession type opportunities, these are two areas where you all can do a lot of help.
Great, thank you. Dr. Bera, we did a lot of work with the Asian Health Service out in California, and were really struck by the stories they told about how COVID it wasn't just COVID impacting the community, it was also the racism that was affecting people, frightening them for coming out for appropriate care. How can we help? What can we do there? I know Congress is active on this issue.
You know, Congress is acting on this issue, and the use of language matters, right? And you know, we saw the prior administration, the prior president, you know, talk about the China virus, and you know, and really, you know, what that did is stoked anger towards a particular, you know, community, the AAPI, the Asian American community, and you know, some of that prejudice has always been there through our history, and I don't need to tell this audience that, you know, when you look at the history of the United States, but you know, going back to internment camps and you know, some of the prior, you know, legislation directed in an anti-Chinese direction, in an anti-immigrant direction, but that all came to the forefront and you know, just as so many other issues, when we're seeing the racial justice, the policing issue, those are all out there in front of us right now. And shame on us if we don't deal with what's in front of us. You know, we saw the border issues under the last administration. And I think that's the call to Congress. And you know, to your prior question, what the activists can do is we need this continued engagement from the public to not allow us to move on to the next issue, because you know, these issues of racism against you know, any community of color, of inequity, they're out in the open. The one thing that I've noticed that has changed, and I think it's a good thing, is you know, in the Asian American community, often, you know, the first generation that's immigrated here, it's just keep your head down, don't attract attention, don't call these things out, et cetera. But you've got this young generation of activists that are speaking out, and you know, as our former colleague and you know, an American national hero, John Lewis, said, is, you know, when you see that injustice, you got to stand up and you got to speak up. And that's the one thing I've noticed in the broader AAPI community. And it's being led by young people, just as I think some of the police reform activism, it was heartening to see the number of young people that were out there, and not just people of color, but you know, people across the entire stripe this past summer. And I think that's what we're seeing in the AAPI community, folks coming together to call it out for what it is.
Congressman Kelly, your district was probably one of those that was very hard hit by COVID, and what's your sense now? Are the resources getting there? Are things starting to change? Are people getting vaccinated? Are they wearing their masks? I mean, what's the sense down there at the community level?
Yeah, I think there's a lot more you know, my district is urban, suburban, and rural. So, but I think that there's a lot more centers open and more convenient places, and a lot more people are taking advantage. I'm a little bit concerned because of what happened with J&J, and will that make people pause? Because actually, I knew a lot of people that wanted to take J&J, so hopefully they still will, because you know, one shot and out, they don't have to remember anything, you know, just have that. But you know, there's of course still more people to go, but there's a lot more centers open that people can get to. And also there were concerted efforts in some parts of my district to make sure that, in fact, at one school district, they held it at a school just for teachers and staff and people like that, so they could, you know, get the school back open. So people were being creative and trying different things. So we could get back to, I'm not going to say normal, because we'll never get back to that, but whatever we, you know, start anew, that we can start anew and truly get started. So yeah, we were, hit hard in some parts, but again, I think that we're definitely coming out of the dark. It's just the concern in my district. We've always struggled some, with economic development. And I know there are, mom and pop stores that have closed, and hopefully with some of the money, maybe they have, they can restart, or in some of the businesses that, barely hung on with some of the resources that, they will get, that they can start to thrive again.
So we have an administration that is talking about building back better. So Dr. Bera, if you have one thing that you would say to the administration in this moment that would make a real change in healthcare, where would you focus them on? What would you say to them that this is something that we need to get done right now?
What I'd say is meet folks where they are. So it's not enough just to get everyone health insurance coverage if you don't have doctors that you can go see, et cetera. Just having a card doesn't actually solve healthcare issues. So go to the communities and meet them where they are, build on the resources and bring resources to those communities that we know are have lack of equity. So again, meet folks where they are as opposed to asking them to come to where you are.
Representative Soto, the National Minority Quality Forum, we are focused on data. Anybody who knows us knows that we live in the data, and we want to, because I think that's how we know where these disparities are, and how do we get them fixed. And we need more data. I think one of the things that certainly we see with COVID, we still don't have a good breakout of the data by race and ethnicity. It's starting to come out, but it's at the end of the crisis, meaning lots of bodies have piled up. So what can we do better here to make sure that we have an information system? We live in the information age, for God's sake. What can we do better here to make sure that we are monitoring the health of the population?
Under the American Rescue Plan, we did require additional reporting on COVID cases, deaths, and vaccinations by race. It's also a huge topic for the Vaccine Equity Task Force. It's also our role in Congress to ask these questions. The CDC is just starting to do that. Under the last administration, not only wasn't a priority, but they didn't want the public to know about these disparities. And we obviously are very focused to make sure we could bring vaccine equity. That was the first topic we talked about when we met with the White House the other day. So this is going to continue to be a focus going forward. We also boosted a few $1 billion in outreach to help with everything from CDC ads to, I know my office, we're doing public service announcements on both Hispanic and AFAM radio in the district, because we're getting to a point where over the next few weeks, we'll go from an access issue to a persuasion issue, where a lot of people who wanted the vaccine, most of them got it by then, but there's a lot of folks who we need to persuade. And we know the reasons why. There's been historic discrimination. The Tuskegee experiment giving syphilis to African-American men in the South. I'm in Florida, which is south of South, and sterilization of Puerto Rican women for decades. My family's native island. So we know the top messengers are medical professionals, followed by faith leaders and neighbors. And, we elected officials are somewhere in the mix, but we know the healthcare professionals in particular are going to be critical as we get to this next transition.
You raise a really great point. I mean, if we're ever going to bring this virus under control, we certainly have to get everyone vaccinated, and we have to do a lot of persuasion. But we also have a lot of disinformation out there. It is not as if we could just simply deliver the message and hopefully people will get it. There's a lot of disinformation. We do a lot of work in community, and people have all kinds of ideas. In California, we were working with the FQHC that were working with the Hmongs, and they thought that the vaccine was going to be used to kill them, that, they get vaccinated and a year later they would die because of, just myths that are out there. How do we manage? How do we, one of the great challenges of the information age is that it's not just domestic, it's international, it's all over the place. How do we begin to get ourselves under control? Otherwise, we're going to have this virus forever.
So we know from the focus groups, the healthcare professionals are the most important, along with faith leaders, because people will believe them over YouTube or Facebook. I've heard the craziest of things, everything from Bill Gates is going to inject you with a microchip to sad beliefs that it's going to make women sterile, to the fact that it was from some aberration because it was stem cells and it's against Christianity. The Pope got vaccinated. And of course, we see all these other misinformation tactics. On the Energy and Commerce Committee, we're also, and I'm working with Rep. Kelly on this, cracking down on the social media companies for their algorithms, advantaging and literally pushing misinformation out there because it gets more clicks and has people stay on the websites longer. So that is another aspect of it. But the most important thing for our healthcare providers, you are the solution. We need you to get out and have individual conversations with as many people who are skeptical as possible, because those conversations are the only ones that have been shown time and time again, regardless of background, to convince people over YouTube and the information that the vaccine is in fact safe and will help protect the lives of you and your families.
Dr. Puckrein, oh, sorry. If I could just jump in about the data. One problem is that across the states, they're not the same. They don't even have the equipment and the tools to collect the data. And sometimes in the very same state, they have different tools. They can't even talk to each other. So that's the other thing. We have to help put together a system where all the states are reporting the same way so that we can get the true facts.
And in the design of the American Rescue Plan, playing off of what Darren talked about, Congressman said, we specifically put funds in there to go reach into the harder to reach communities, identify those trusted groups, whether that was clergy, whether that was a nonprofit or a school, and then partner with those and push those funds to the folks that were going to be most effective at addressing this misinformation or vaccine hesitancy. Some of the legitimate, based on historical practice. Certainly in the African-American community, there's some concern based on history. But again, the best messengers are going to be folks that are already trusted by the communities that you want to reach.
And I also think we have to think out of the box, because young people, is it faith-based that, is that who they're listening to? Or, we have to, people get their news and messages and communication in different ways. So we have to, find out who those people are. But actually each person, that's gotten a vaccine, they can actually be a role model, to the person within their family or their group of friends.
We talk a lot about the vaccines. Congress also and the administration bought COVID therapeutics. There are these medications out there for people who become positive for COVID. The FDA approved them for people over 65, as well as people with asthma, diabetes, obesity, and other comorbid conditions. They're not being used. And when you take a look at minority communities, the infusion centers, these medications have to be infused. They can't be injected like a regular drug. You have to go to an infusion center. These infusion centers are not in minority communities, even though we have these high levels of hospitalizations and death, and the communities don't know about them. What can we do? I know conversations have been had with the administration, but really we need to make sure that we don't lose lives when we have medications that the government has already paid for. These are things that are already out there and they're being underutilized. Is there a way in which we can get the message out and really help save a lot of American lives?
I mean, I think we need to use some of the tools that my colleagues, have already talked about, but we need to go where those folks are, whether it's to independent senior places or nursing homes, or, we need to go where those folks hang out, whether it's even going to maybe whatever their illness is, there's a place we can go, like the, diabetes center, or things like that. We have to think out the box. We can't do things in the usual way, and we have to send, as we've talked about, trusted people to those places.
Yeah, and
Dr. Bera, please.
It's something that our colleague Jim Clyburn talks about as well. Setting up mobile clinics. A reason why so much of the funding is also focused at community health centers, FQHCs, is because they're going to be in many of these communities, and empower those FQHCs, give them the, if they don't have the specified training and support, give them that support. Because again, I think as Robin was saying, meet folks where they are, instead of, go into those communities, and I think you'll get a much higher response rate and make these therapies available.
In Central Florida, the health departments have been key, but the federally qualified health clinics that Dr. Bera talking about have been sort of the godsend. Mobile COVID testing units, because they're getting funds directly from the feds, they respond very quickly to us in our office. Sometimes with local governments, they have their own political structure, so they're not always so responsive. And now they're getting mobile with the vaccines, and they're getting federal allocations. We included a huge amount of funding in the American Rescue Plan for federally qualified health clinics. So I've had a lot of my local FQHCs over the last 3 to 4 weeks say, representative, whatever you need, you tell us, we will be there. Church, business, you name it, because they're now getting a huge allotment of vaccines from the federal level. They weren't until just about 3 weeks ago. And they have the mobile medical units available. One other thing I also want to kick in is rural broadband and an upgrade of broadband under the American Jobs Plan that we are working on is another key factor, not only in getting more knowledge of the therapeutics, but also just in general with telehealth for a lot of folks. While I have, like Robin, both rural, urban, and suburban, I have both African Americans, Anglos, and Hispanics in the rural areas, and their internet's lacking, and they don't have as great access. The one thing we are benefited from is we have a great, strong hospital network in Central Florida. So I could tell you in Central Florida, communities of color have direct access to remdesivir and monoclonal antibodies because we have such a strong hospital network in every aspect of the district. But mobility in some of the rural areas to get folks there has been a little more of the challenge.
And, I wanted to throw in, I do a lot of work around telehealth. Not that I ever thought I would, but I do. And we feel like if done correctly, telehealth can be, the great equalizer. It won't solve everything, but I know even, my husband's a doctor and he never did anything close to telehealth, but he's been doing it for over a year now. And because he actually made home visits. So now he couldn't do that. But even him calling the people, beside checking on their health, this idea that someone called, people were like, thank you so much. Someone checked on me just for their mental health. It did wonders, because sometimes he's the only person, that comes to their home, or their son or daughter is not close. So telehealth is really important. And what Darren said, reflects my district so much, as far as the population and, those kind of things. And again, in those rural areas, there's, some of the areas, there's not even a tarred road. The road is the rocks, so if you don't have a car, you are absolutely in trouble.
This administration is talking a lot about investment in new infrastructure to build back better, and certainly they're bringing new legislation forward to make big investments. And wanted to get your sense of what should be thinking about in healthcare. I love the idea they think of, let's think of infrastructure in new ways, that it's more than highways and bridges. We really want to build infrastructure into the future, and would love to get your sense about what should we be thinking about in healthcare. I know the advocates here would love to get your sense of it, because we want to push, we want to go. So I'd love to get you thinking about how, as these new pieces of legislation start to move forward, what should we be looking for and how can we support?
But defer to the doctor first.
Well, so both Robin and Darren touched on, we realize how important connectivity is in terms of broadband and so forth, not just in the healthcare and telemedicine, but for the kids that have been at home trying to get their education. Again, we know rural communities and communities of color have had less access to those. So let's rectify that, and let's create equity in broadband and connectivity. But two, it's not talked about a lot, but in this jobs plan, which includes infrastructure and takes a broad definition, President Biden put in, I want to say it's $400 billion roughly for home healthcare workers, for AIDS. That's the future, right? Most people, when they're sick, especially at the end of their life, they don't want to be in the hospital. They want to be in their home. And unfortunately, often the primary caregiver is a family member who may have to quit their job to care for their loved one. Let's rectify that. We could create a whole bunch of jobs. We can actually start to bring down the cost of healthcare. And we can, again, you've heard me say this a number of times, meet folks where they are. Like, none of us wants to die in a hospital connected to a bunch of tubes. Most of us want to receive our care surrounded by our loved ones in our home. And we can do this, and we can create a bunch of jobs. We can actually get better healthcare outcomes. And we can lower the cost of healthcare, I believe, if we do this right. And again, that's one that doesn't get talked about a lot, but it does have me pretty excited, if we do this correctly, that, particularly again, for these less resourced communities, we could do something good for the country.
I would like to see, and I know it's not going to be overnight, but, concentration paid on diversity in healthcare. Not everyone has to be a doctor, like the doctor, but there's all kind of jobs, in healthcare, and, diversifying the healthcare pipeline is so important. There's just been so many studies that show people do better when it's someone that looks like them, or at least understands the reality, of their situation. I work a lot on maternal mortality, and it's a shame what happens, in this country. So I think the idea of community healthcare workers, doulas, all kind of people that'll make life easier for everyone, no matter how much money you have, what your ethnicity is, what your race is, where you live. We just have to do better. There's a 7-mile space in Chicago. When you leave the south side and go 7 miles, might be 9 north, your life expectancy increases 30 years. So when you go north to south, it decreases 30 years. That's ridiculous. We have to do better than that.
One of the numbers that sticks in my mind is that healthcare is actually the largest employer in the United States. Mm-hmm. Everybody thinks it's manufacturing, but it's not. It is healthcare, and it's local, and it's outside the global competition, because it's delivered local, and we can support so many in our community if we can build strong healthcare infrastructure. But when you look around, we're closing rural hospitals, right? Which makes no sense, because they're often the largest employer in the community, and all of a sudden you take that away. So I think there's a real opportunity, as you suggest, to make real significant changes in people's lives while putting people to work who can support them.
And just to add to that, I'd be remiss if I didn't mention that Representative Kelly and I are on the committee that review this aspect of the American Jobs Plan, the LIFT Act, and it provides for funding to modernize hospitals and federally qualified health clinics, particularly those in urban areas that have been around 50, 60 years, and some of our rural areas. Rural broadband will go through our committee as well, which we talked about that being key for telehealth, and a little more in the CARES infrastructure. We have to understand that the United States' demographics by population is kind of like an hourglass, where we have the boomers, which used to be the biggest demographic, but as they're aging and passing away, it's now millennials that are now the biggest demographic. And then Gen Z folks like me are kind of in between. So when you look at this big group of folks that we have a real decision to make about quality of life and quality of their senior years. And it'll be interesting because we have some folks saying that's not infrastructure, but a lot of their voters are in that demographic. So I guess there'll be a big debate over whether taking care of our seniors is infrastructure or not. I look forward to continuing those debates. And lastly, there was a letter that went out today requesting that Biden, in his next big bill that he's proposing, the American Families Plan, lowers the age of Medicare eligibility to 60 years of age. In Central Florida, we have folks who literally throw big birthday parties when they hit 65 because they finally don't have to be on private insurance anymore. And we know private insurance works in a lot of areas, but when you get to be in that 55, 60 to 65 time period, the beauty is we have a lot of cures, a lot of solutions to improve people's quality of life and extend their life expectancy, but those aren't cheap. And so it ends up being $1,000, $2,000, $3,000 or more for folks. So even if we could get it from 65 down to 60, people shouldn't be having 65-year birthday parties celebrating that they could finally get on Medicare because they've been paying thousands of dollars a month for years. And when we know the solution, the ACA does a great job, but with regard to folks who are just below that limit, we really can do better by lowering the Medicare age down and helping with that.
One of the things that happened with COVID was really Operation Warp Speed and the development of the vaccines. They came to market really in a year. Obviously, there was a lot of research that led up to their development, but nonetheless, going from 0 to 100, and this administration now having vaccinated 200 million people, which is a stunning number. If you think about it, we just talk about, you started in December and here we are in April and you vaccinated 200 million people. That's a stunning accomplishment. But also it says that there are probably new ways that we can think about how do we address some of these diseases that are impacting our community, where they become, my word, infrastructure, in the sense that we're making a very strong investment in order to bring these diseases under control. I would hate to see the next generation have to deal with diabetes. I mean, it's something that we should really put our foot on the gas and deal with. And there are lots of new therapies coming out for cancer. We're operating at the genomic level. So are there good lessons from COVID about these public-private partnerships that we may be able to take forward and really effectively bring about rapid and quick change in our community as it relates to health?
Absolutely. I think science is cool again, right? You're
in some quarters.
It's always was. You're seeing this resurgent interest, and the truth is, most of us in the medical profession a year ago would have said 16, 18, 24 months before we have a vaccine available. Well, we've got 3, soon to be 4 or 5 really safe and efficacious vaccines that are out there. And those didn't just happen overnight. The Moderna vaccine, a lot of that was partnering with the NIH and the funding to build this platform of safe and effective vaccines. If we just take that ingenuity to a disease like diabetes, we can certainly solve it. We could certainly at least make it much more treatable and controllable. We just got to put our minds to doing it. And You know, the truth is, this isn't about more money. We spend money in the wrong place. You know, Robin's been a leader on maternal mortality and Black infant health. If we actually just spent a little bit more time and focus on prenatal care, on, you know, and brought those services there, we'd save a lot of money, because the cost of neonatal care and the neonatal intensive care unit, one in terms of morbidity, but also just direct costs. We just spend money in the healthcare system in the wrong places. And we could do a better job.
Well, we, you know, in the patient advocacy community, we obviously are looking to accelerate knowledge, to increase access to new therapies, particularly in the minority community. If you look at the data right now, what you'll see is that more often than not, minority populations are getting old therapies, and it's impacting their life expectancy, the quality of their life. And so there's a real need here to reimagine what we're doing and getting a healthcare system that's really prioritizing patients. And so anything that we can do as this legislation starts to move forward, as we start to think about infrastructure in a different way, because healthcare is infrastructure. At the end of the day, it's an important part of our future. And it's something that I'm sure I'm channeling all of the patient advocates who are online, who would, I think, deliver that message to you, that we got your back here. We wanna change the system and really accelerate how we are bringing new therapies and making sure that they're available to populations.
Well, I've got a request of the advocates, as well as my two energy and commerce colleagues. You know, the advances are remarkable in healthcare and gene therapy, et cetera. And, you know, we're on the cusp of coming up with a cure for sickle cell anemia. And when that happens, we're going to want to make sure that's readily available to folks, because we know how devastating that sickle cell is to particularly the African American community. But we also know that therapy is going to come with a big price tag on it. And where we could use the activists, but again, you know, want to work with my colleagues, is yes, we're going to spend more money on the front end, but if we can cure sickle cell, we will save so much money on the back end, from hospitalizations, lots of productivity, everything else. We just have to figure out how to get Congress and the Congressional Budget Office to recognize that we might spend $10 on the front end, but we're going to save $100 over the course of a lifetime.
So
Sure.
Sorry, go on.
Sure. If I may add, you know, everybody talks about how we got this vaccine in breakneck speed, when really it was decades of National Institute of Health work, and Dr. Bera alluded to it a little bit. But if I would have told you 20, 30 years ago, we'd take a fat cell, put RNA in it, inject it into you, and upgrade your immune system to create a spiky protein that would mimic the COVID, so that you can then develop white blood cells to attack COVID and protect yourself, it would be considered science fiction, much like the immunology that you're referencing for cancer treatment, upgrading our white blood cells to attack the cancer. Just mind-blowing stuff that was decades in the making. It wasn't that the vaccine was developed in 3 or 4 months and then we tested it for 6 months. It was developed over years and years and years. And that kind of ingenuity is enough to give us all hope. When Social Security first came out, it was at 65 because the median age life expectancy was like 67 or 68. Now, if someone passes away at that age, people think, oh, they went too young, you know? So we live in an amazing time of amazing cures and possibilities, but we do need to fund it. We do need to make sure it's equitable. And that's the difference between that 30-year life expectancy gap that Congresswoman Kelly was talking about, Robin, about. It's about justice in healthcare to bridge those gaps, because a lot of the cures are coming online. We just need to make sure that we have great access for all Americans.
And I just want to say that, you know, I associate myself with what my colleague said, but, you know, the lack of equitable healthcare is a civil rights issue. I mean, people die because, they don't have access, or they don't have the proper care. So that's where the activists come in. We need you to help us, or to help you, we need to be in this together and, get support from the activists and those kind of things, and speak up to us, teach us what we need to know, the barriers, the opportunities, and things like that. I'm going to have to jump off now because my schedule is so tight, but thank you so much. It was an honor being with my colleagues, and of course, always you, Dr. Puckrein. So thank you so much.
Oh, thank you so much. We appreciate you being here. I just want to pick up on Dr. Bera's point, because we're getting near the end of the hour anyway, but he mentioned sickle cell, and I want to make the larger point on sickle cell. So somewhere around 65 to 70% of everyone with sickle cell in the United States are on Medicaid. Their life expectancy is about 48 years, right? And you can watch them as they turn in their mid-20s to 48. It's just one hospital experience after another. It's a pretty miserable downhill slide, quite frankly. The Medicaid program is not built really to take on the question that you're raising about these new therapies, and what are we going to do when states have to balance their budget really, and as these new therapies come online. That's just but one example. Right now we have 80 million Americans in Medicaid as a consequence of Medicaid expansion, and so it's going to require a lot of really important thinking about how we make sure that program doesn't become a disparities program because it's really not funded correctly.
I couldn't agree with you more. And it is something we're readily thinking about. But the answer is going to be in making that therapy available so you avoid those repeated hospitalizations, that loss of productivity, that disability, because the cost of all of that is of magnitude greater than the cost of giving the cure. And we're just going to have to figure out how to have the will to make that happen. That we're going to pay for it on the front end, but we're going to save so much more on the back end.
And just to add to Dr. Bera, we just in the American Rescue Plan added a big incentive to states to fund Medicaid more. All states that expand Medicaid, which there are many, I think we're at almost 40 something now, they get an additional 5% in base Medicaid funding from the federal government. So we're stepping up our federal share. That's the first significant increase in quite some time. So we are looking to make sure to fund the Medicaid program, and that's Congress's job to do so. And that commitment we just saw in that first bill in quite a long time is the best evidence that we are committed to doing it, as is President Biden.
I really want to thank our members today for taking the time to join us. We want to be there for you. We heard your message, and we're going to do our best to be your eyes and ears on the ground because America is changing. There is a new majority that's starting to emerge in the country that needs healthcare. And I think it needs a thoughtful program that is designed to make sure not only are we helping people stay healthy, but there are jobs associated with it. This is not just a lose situation. This is building a new economy around communities that heretofore have not had healthcare. And so we are your partners in this, and we will work very, very hard in order to make sure that we're communicating with you what we see on the ground. We will be in those communities, as Dr. Bera suggested. So I want to thank you so much for taking the time to come and be with us this afternoon. And if there's any way we can be helpful, please let us know.
Great.
Thank you so much.
Thanks so much.
Bye-bye.